Welcome, everybody. Hello, and welcome to the latest WomenHeart Heart Talks webinar. I'm Selena Goret, the CEO of WomenHeart. And for those of you who are new to us, we are a patient-centered organization that provides support, education, and advocacy exclusively for women living with or at risk of heart disease. We're so thrilled today to be co-hosting this webinar with our friends at the Mended Hearts. They are also a patient-centered organization focused on heart disease. And we have my friend Jody Smith with us, and she is their director of programs, to give a welcome. But before we do that, I'd like to acknowledge and thank our sponsors for this webinar, the BMS Pfizer Alliance, who have just been incredible supporters on this issue. So before we get started, I'd love to turn it over to Jody.
And I agree with Selena. We are so excited to be partnering today. We're a very good combination together because we address all forms of heart disease and across the lifespan. And so we just really are glad to be here today, glad to be partnering with WomenHeart, and glad to be talking about this very important topic. So thank you so much, Selena.
Thanks so much, Jody. So today we're going to be talking about atrial fibrillation, or AFib. We'll have a discussion, learn a little bit about what AFib is, what the signs and symptoms are, how it's diagnosed and treated, and what it's like to live with AFib. So we're going to cover quite the gamut of information. So let me introduce our speakers. I am so thrilled that we have two medical experts here with us today. Dr. Annabelle Volgman is the medical director of the Rush Heart Center for Women at Rush University Medical Center. She is the McMullen-Eibel Chair of Excellence in Clinical Cardiology and the Professor of Medicine at Rush College of Medicine. She's also our on WomenHeart Scientific Advisory Council, and a 2019 Wenger Award winner for excellence in medical innovation. So we're really pleased to have Dr. Volgman with us. We also have Dr. Jeanne Poole, who is also an esteemed member of WomenHeart Scientific Advisory Council. She is a professor of medicine and an attending physician and the director of the Arrhythmia Services and Electrophysiology Laboratory at the University of Washington Medical Center in Seattle. So we're so pleased to have both of you. Welcome. We also have two patient experts here who can talk a little bit about what it's like to live with AFib. Genevieve Fire-Halvorsen is a WomenHeart champion from the class of 2019. She's coming to us from Los Altos, California. And Ronda Tamerlane is a WomenHeart champion from the class of 2022. She's also joining us from Northern California, from Sonora. So welcome to the two of you, and go California. So why don't we get started? Dr. Poole, I'd love to start with you. Can you kick us off by telling us a little bit about what AFib is and what the signs and symptoms are, and how somebody would recognize that they might have AFib?
Sure, absolutely. Well, first, atrial fibrillation is the most common rhythm disorder that we see in all human beings. And we can just refer to this anatomy, and I think most people understand that the heart has four chambers. So it has the two upper chambers, which are called atria, the two bottom chambers, which are called ventricles. And our normal heartbeat starts spontaneously up in the right atrium, which is really kind of amazing when you think about it. There's a group of cells that just automatically start up. We call that depolarization, and they kick off the normal heart rate, and that heart rate varies according to whether you're sleeping or whether you're exercising. And of course, you know your heart rate goes up with exercise. But what can happen, and this is true for anywhere in the heart, but specifically for atrial fibrillation, is that some abnormal impulses can start up. And for atrial fibrillation, those abnormal impulses actually start up in the left atrium. And you can see on this figure that in the left atrium, sort of the upper right-hand chamber, there are these kind of dark ovals, and those dark ovals represent what we call pulmonary veins coming in and plugging into the back of the left atrium. And those pulmonary veins are actually bringing in the new oxygenated blood from the lungs. That's how we get oxygenated blood into the heart, is through the left atrium. And then that oxygenated blood goes down into the bottom left chamber and is pumped out to the body. And when you take your pulse, that actually represents the contraction of the ventricles, or the bottom chambers of the heart. So you're not actually measuring your pulse by how fast anything is happening up in the atrium, but how fast it is happening in the ventricle. But where these pulmonary veins plug into the upper left atrium, there's a change in the type of tissue. You switch over from vein tissue to heart tissue. And anytime you switch sort of tissues like that within the heart, that just tends to be a really vulnerable area for arrhythmias to happen. And so around these pulmonary vein areas, you can start getting single extra heartbeats. And then those extra heartbeats can sort of take off and get going and form kind of electrical rotors, and they spread throughout both of the atrium and the top of the heart. Well, those electrical impulses are still going to try to get down to the bottom of the heart. And we have a normal braking system that's right in the middle that separates the two bottom chambers. But right at the top of that middle section, we have something called an AV node. It's just kind of a funny terminology, but what it really does is it tries to limit how many impulses get to the bottom of the heart. Well, unlike the normal heart beat, which would be one beat in the top of the heart, getting down to the bottom, followed by one beat, which you can feel as your pulse, these atrial fibrillation rotors are all trying to bombard that area of the heart. As many of those as can get through as possible are going to get through. And so it ends up being an irregular heartbeat, and it can be extremely fast depending upon how healthy that normal sort of what we call conduction system is, that those electrical speedways that bring the electrical impulses down to the bottom of the heart. And so the hallmark of atrial fibrillation is generally a faster than normal heartbeat. You're sitting there, you're not exercising, and your heart rate is too fast, but in particular, it's very irregular. Now, the symptoms that people can feel really vary, but before I go on to that, if you look at the bottom of this figure, you can see that there's an electrocardiogram. So this is the manifestation of the electrical impulse that can be picked up on the skin of your chest, you know, when you have all those electrodes put all over your chest and you get an electrocardiogram. And you can see on the left with a normal heartbeat, it's really regular, super regular. There's a small, tiny bump before the big bump. And what that represents is what happens in the top of the heart, followed by what happens in the bottom of the heart. Now look at what this electrocardiogram looks like when you look at the atrial fibrillation. First of all, you can tell that these big spikes, they're all irregular. They're just all over the map. And in between that, you also see this kind of just low level, wavy sort of pattern. There's nothing that's distinct or precise. And so that's what it looks like in an electrocardiogram. So what might you feel? Well, symptoms can vary dramatically across people. The classic symptoms are that you feel that irregularity, just like if you switch suddenly from normal to abnormal, you're going to go to feeling something that feels like there's something roiling around in the side of your chest. Some patients call it a flip-flop feel. They can just tell that there's something amiss in the chest. And that's one of the issues with atrial fibrillations. The symptoms are highly variable. So yes, the classic is I might feel my heart pounding, or I might feel like my heart is taking off to the races, or I just have these kind of erratic beats. I check my pulse and I can tell that it's irregular. So it's great if somebody has classic symptoms because they can report those to their healthcare providers, and that's going to immediately clue them in that maybe something's amiss here and maybe there's an arrhythmia going on. However, some people don't have those classic symptoms. And so they show up maybe because they feel tired, or they feel suddenly dizzy, or that even over time, they just kind of lost steam, all the way to patients who don't feel this at all. How it is that patients don't feel this is kind of a mystery to me because it's so irregular and so different, but there's no question that some patients go to their primary care physician for a routine follow-up. The physician can identify when they're taking your blood pressure and heart rate that something's amiss, and then they get an electrocardiogram and document that, oh gosh, you know, did you realize that you have atrial fibrillation? But the classic symptoms are rapid, irregular heartbeat, that many people will feel that, and that's what prompts them to get medical care.
Thank you so much, Dr. Poole. I mean, gosh, I've learned a lot in just the last 5 minutes, so I appreciate that. I'd like to bring Dr. Volgman into the conversation. And Dr. Volgman, if I can ask you to talk about, we just heard that there are a variety of symptoms that individuals with AFib might experience, but can you talk more specifically about any differences that we might see in symptoms between men and women?
Sure. Can I have the next slide? So as Jeanne was saying, it's so variable. I have patients who feel nothing at all, and we get an EKG and their heart rates are so fast, they're in atrial fibrillation and they feel nothing. They're fine. And then I have patients who have a little bit of atrial fibrillation and they feel every single beat and it keeps them up at night. So, we have such a variety of symptoms. So that's why it's really hard to pinpoint. They do feel some shortness of breath. So women compared to men are more symptomatic. That's what we are finding in the studies, the epidemiologic studies, the surveys. They are just more symptomatic than men. There is a lower prevalence. I don't know if Jeanne got to this, but in terms of when people get atrial fibrillation, at younger ages, there are definitely more men than women getting atrial fibrillation. It takes a bigger heart to get atrial fibrillation, and men are bigger. And so they have bigger hearts that can make the heart go into atrial fibrillation. But at a later age, because women live longer, they're more older women, the absolute number of women compared to men is really the same, because there are a lot of 90-year-old women who have atrial fibrillation and the men don't live as long, although that longevity gap is decreasing. So we really need to, pay attention to what's going on with women. I'm glad that men are living longer, but we want the women to live longer too, and with good quality of life.
Absolutely.
So,
yeah.
And women, for some reason, have a higher risk of stroke when they have atrial fibrillation. So we have to be careful. Celine, do you want me to go through this slide, or do you want to ask me more questions?
Well, I want to sort of bring Dr. Poole into the conversation, because I want to ask both of you. You've talked a little bit about, symptoms, and now I want to understand, or help the audience to understand, how do they go about getting a diagnosis of AFib? So what does the diagnostic process look like? What should patients expect? What should they ask for, perhaps, if they suspect they might have AFib? And then what else is there to kind of think about in terms of post-diagnosis? What is the management of AFib look like?
Jeanne, do you want to start?
Yeah, sure. I can start with that. So the hallmark of making a diagnosis of atrial fibrillation is you have to prove it on an electrocardiogram of some sort. That really is it, because people can have a feeling of skip beats, and it may not at all be due to atrial fibrillation. Maybe they just have something benign going on, like a single extra heartbeat here and there that we all have. Or maybe it's an abnormal rhythm from the bottom of the heart. So it is absolutely critical that you document that the rhythm, in fact, is atrial fibrillation. That might be because the patient is in it for long periods of time and you catch it, so to speak, by doing a routine electrocardiogram. But oftentimes the patient has those symptoms. And so what the physician or healthcare provider needs to do is order some other rhythm monitoring strategy to try to identify that. We call that a Holter monitor. That's based upon the name of the person who originally made up these monitors, but it can actually encompass a variety of different kinds of monitoring strategies. So in the current day and age, one of them, and probably the most common that we use, we call patch monitors. So it's kind of a big sticky Band-Aid that you can slap on your chest, and that can record every single patient heartbeat up to 14 days at a time. And then there's another type even that can record up to 30 days at a time. And so we need to try very hard to document whether or not the patient's symptoms that they are having are indeed due to atrial fibrillation or not. If those approaches don't work, but yet the patient is having intermittent symptoms that are highly suggestive of having atrial fibrillation, we even have the opportunity now to use what we call an implantable cardiac monitor. That kind of sounds maybe scary, but it's really not. It's a little tiny, maybe 1.5 inches long at most, very, very thin, a couple millimeters wide and a couple millimeters thin, monitoring device that you just make a teeny weeny incision in the skin of the chest and just kind of slip it under the skin, and it can stay there for up to 3 years, which is when the battery wears out. But it's a great option for those patients who really are suspicious that they may be having atrial fibrillation and you just don't catch it at the time you're using these other monitors. But it's so important to keep trying to document whether or not the patient has this rhythm or not, because it's associated with a risk of stroke. So that is the key thing. There are other aspects to atrial fibrillation, which we'll talk about, is how do we treat it? How do we manage symptoms? But the key thing is we can't miss this rhythm, because we need to identify whether or not the patient has that rhythm and if they are at risk of a stroke.
Dr. Poole, just to jump in here as a follow-up question, from what you're saying, you're suggesting that because of the kind of idiosyncratic nature of AFib, you may not catch it in the 14 days. You may be totally fine within 14 days. You're saying it may take longer. You may need a longer period of time to catch it, because 14 may not be enough, 30 may not be enough. You may need to have a much sort of longer term, monitoring of it. I guess my question is, what happens if the doctor comes back and says, "Oh, we didn't see anything on the 14th day. You're fine."
Yes.
Can I just jump in
Sure,
here?
yeah.
Yeah, so I was going to add, we now live in a world of wearables, devices like the Apple Watch, like,
right
lots, exactly, lots of Cardia, Kardia monitor. You can buy that on Amazon for $79. I mean, we are now living in an age where if you are having any symptoms of palpitations or skipping beats, you can buy a very inexpensive way of figuring out what your heart rhythm is. Now, it's not going to be as, continuous as the implantable loop recorder or the monitor that Jeanne was talking about, but it's really a great way to self advocate for your what's going on with your heart. So I would suggest, and I always in the right patient population, I will always pursue those palpitations, because if they have a risk of stroke, we calculate the risk of stroke, and those people, I will pursue it to, until I get a documentation of their arrhythmia during their symptoms. So now there's inexpensive ways of doing this, which is so great at this point.
Yeah, I agree. These are consumer products. And so, they're made by companies who, of course, are for-profit companies. But I will say that they work well. The two that were mentioned, the Cardia, the thing about that one is that you have to have your symptoms lasting long enough to, put your fingers on this little metal plate.
Right.
The Apple Watch is more expensive, but if an individual patient wants to have an Apple Watch, the way in which the Apple Watch measures your heartbeat and puts it through an artificial intelligence algorithm is pretty good for suggesting that you may have atrial fibrillation. It's not diagnostic, but maybe giving you the warning that you might, and to encourage you to then follow up with your healthcare provider. So what's really great about this compared to 10, 15 years ago is we really do have a plethora of ways to really try to identify if somebody's symptoms are or are not due to atrial fibrillation.
Absolutely. And I want to emphasize what I see on my Apple Watch, right? Which is that your watch is never going to diagnose this. Your watch is not a diagnostic tool. It's a suggestive tool.
Right.
So that is the information, the kind of information you want to share with your doctor when you have the to make that point. Let's move on a bit to treatment. I understand that oftentimes there are unique characteristics of AFib that we see in women. So I don't know, Dr. Volgman, you might want to talk.
Yeah, sure. Can we have the
that a
next
little-
slide? So I'm going to talk about the non-interventional treatment of atrial fibrillation because that's what I do. First of all, like I said, we calculate your risk of stroke. If you're a woman, that actually adds an added risk for having a stroke. If you have any other risk factors, you're more likely than a man with the same risk factors to have a stroke. So, there's something about women. We still don't know why they have that higher risk, but they do have that higher risk of stroke. So make sure you are put on anticoagulants to prevent that risk. That medication or the new drugs that can lower your risk is so effective that it's easy to take. You don't have to worry about what you're eating and what your levels are. You take it, once or twice a day, and that's it. You're protected. It can lower the risk of stroke by about 60 to 80% in different people. The other thing that you want to do is make sure you don't develop heart failure. And that's where the drugs that slow your heart rate down, because when atrial fibrillation happens, people tend to go fast, and that can eventually weaken the heart and cause heart failure. So we treat women with drugs that will lower the heart rate. And unfortunately, women have been treated with digoxin more than other drugs and more than men. And there is an association with digoxin use with breast cancer and increased mortality. So that is the third line of drug that we should be using. And unfortunately, for some reason, that was, being used in women more than men. So we really, if you're a woman, make sure you're on a beta blocker first. And if you can't tolerate a beta blocker, use a calcium channel blocker. So I'm going to leave the rest to Jeanne because this is what she does.
Yeah.
Right. I'm going to mention one aspect of AFib treatment that is not sort of a couple of things that before we actually get into actual procedures, but we also talk about risk modification. And one of the things that we now understand that I don't think we understood so well a decade or so ago are the importance of other medical problems that people have, or looking specifically for medical problems that may increase how much atrial fibrillation people have, and that you can actually significantly reduce that by paying good attention. So if you're a patient that, say, has high blood pressure, controlling your high blood pressure really well makes a difference. If you're a patient with diabetes, controlling your diabetes really makes a difference. Being on good heart failure medications if you have heart failure. Making sure that you have good weight control. So we know that patients who have significant problems with obesity, that also can increase how much atrial fibrillation people have. Sleep apnea is another example, and we really probably underdiagnosed sleep apnea in the past, and so all patients refer to us for atrial fibrillation management if they haven't already had a sleep study. We do send them for that. We of course rule out that the cause of the atrial fibrillation isn't due to an overactive or seriously underactive thyroid. And then I will bring up alcohol because for a long time, this alcohol in moderation is okay. That might be true for a lot of patients, but overall, I think it's important for people to understand that alcohol is a direct toxin on the heart. And it really is what we call pro-arrhythmic, meaning it is a substance that increases the risk of having arrhythmias. And so our recommendations now are quite strict compared to what they used to be. For patients with heart failure, we ask them to not have alcohol at all. And for patients with atrial fibrillation, we certainly ask them to decrease their alcohol if it's significant and really consider not drinking alcohol at all. So we kind of go through all of these risk factors or risk modifiers, if you will. And then we get around to the actual treatment. So Annabelle talked about the use of digoxin and beta blockers and calcium channel blockers. So that's heart rate control. And that is, really, really critical. You can't let somebody be wandering around with a fast heart rate. They're going to get heart failure, like what Annabelle said. So that's really important. Then we get to something that is called rhythm control. So that means trying to actually decrease how much atrial fibrillation somebody is having. We call that atrial fibrillation burden. And it's important to understand that for the majority of people with atrial fibrillation, it is part of having chronic heart disease. And we aren't going to get rid of all atrial fibrillation. In fact, that's really not necessarily the goal. But we certainly want to keep people in normal rhythm as much as possible. Well, why is that? Because we know from randomized clinical trials that keeping people in normal rhythm significantly lowers a number of important cardiovascular outcomes like cardiovascular death, cardiovascular hospitalization. And so the sooner that we identify atrial fibrillation, the better off a patient is going to be. And you can do this with both certain rhythm controlling medications that are different than the beta blockers, calcium channel blockers, and digoxin. There's a whole group of medications that we can potentially use in patients. Or you can use an invasive procedure called catheter ablation. So when you do one or the other, well, right now guidelines would say that for a newly diagnosed patient with atrial fibrillation, using at least one medication upfront is okay. If patients have significant risk for using any of the medications, and it turns out that women actually are at higher risk for some of the side effects of certain of these rhythm medications, that it's also okay to do the procedure. All invasive procedures have risk, but we've been doing this particular catheter ablation for atrial fibrillation since the early 2000s. It's highly perfected at this point in time. The approach to doing it is safe. Now, up until recently, and you still need to sort of look at the literature as a whole, women were in general referred less often for catheter ablation than men. I think that probably still holds true. Whether or not in good hands and experienced sites, women patients have more complications is a little bit up for sort of revisiting that data in a recent randomized trial called Cabana. So that was done by highly selected patients, sites, people who really knew how to do AFib ablations. Well, actually, women did just as well as the men did in terms of the success rates, and they didn't have any more complications. But clinical trials are always a little bit hard because these people are being followed very, very closely, and you're enrolling patients at places that have a really great track record. But it is true, I think, that sometimes women are not referred because of the concern of higher complications, and simply are just not referred as often. They're just not considered for catheter ablation. They just are left on medications when maybe that would be a really, really great option for them. So before going on to the last topic on this particular slide, I think I'm just going to stop there and, Annabelle, see what other comments you might have. And you're on mute.
Thank you, Jeanne. I'm sorry, the usual. Oh, you're on mute. I don't know if we want to answer questions. I accidentally said that I answered a question and I didn't. So can I just quickly answer that one?
Why don't you answer that one, Dr. Volgman? But I really want to bring the champions in and then come back to the question.
And then I'll type the answers for the others.
Yeah.
She said, is Tickerson best for AFib in terms of medications, or Watchman better for most people? So I don't know if Jeanne emphasized that a Watchman is not a treatment for atrial fibrillation. It is a way to prevent blood clots from getting out into the bloodstream. So it protects people from strokes. It's not the same as treating the rhythm. Tickerson is a rhythm control. So I just wanted to make sure that was answered.
And maybe we can get into a little bit more about that left atrial appendage closure, after we, answer some of these other questions.
Yeah,
Sure.
I'd love to bring in our WomenHeart champions. Let's start
Sure.
with Genevieve. Genevieve, I know you were diagnosed with AFib several years ago. Can you tell us about your experience of getting a diagnosis, and once you were diagnosed, what factored into your decision about the type of treatment you decided to have?
Great, I'm really happy to be able to tell my story to everyone, and hopefully it will help people. I've always been really healthy. I'll just put that out there. I'm a longtime bicyclist. I was competitive. Before that, I was a competitive swimmer. I just was healthy. It took 9.5 years to get my diagnosis. I started having symptoms in 1998, and they came on only while I exercised. And so I would have palpitations, pretty classical symptoms now that I know about it. Palpitations, chest pain, shortness of breath, weakness in extremities. So heart palpitations like crazy. So I contacted primary care physician, explained what was going on, and they ordered tests. They ordered ECG. I had a 24-hour Holter monitor, blood pressure monitors overnight, allergy tests, thyroid tests, and I even had a test for a really rare type of adrenal tumor. And I did have allergies. The Holter monitor picked up high heart rate overnight, like up by 100. But since everything else was normal, I got diagnosed with general anxiety disorder and put onto an anti-anxiety medication, which was really hard to get off of, I'll say. They also gave me beta blockers for the high heart rate. So I would check in periodically because the symptoms just were getting worse and worse. And they got more frequent. They used to just mostly be exercise, and then I was being kept up overnight with severe palpitations, sweating, tremors, uncontrollable shaking. And it just got worse and worse. By the way, I found out later on that a primary care physician, and I have my chart, here is the exact wording. She has a bit of a mysterious and mythical approach to her healthcare. And the issue with that is that follows you for years once that gets in your chart. So, I didn't want to be a bother, but I would keep checking in. Finally, in 2008, mind you, this is like 9.5 years later, my heart rate would not go down. I was commuting to work on bike, and I ended up in urgent care, and they gave me a Holter monitor after that. I took it out for a little bike ride, and within 2 miles, apparently I had an episode. You can imagine getting called by your primary care physician on a Sunday. She says, you need to come in right away. I was terrified when I found out. I'd never heard of AFib. I knew no one with a heart rhythm problem. I thought I was going to drop dead from this, like people do on basketball courts. I had no clue what it was. So I got referred to a cardiologist. He put me on rhythm control meds. I don't know if he put me onto anticoagulant at that point. Mind you, when I first started having these symptoms, I was 41 years old. I was not the demographic that typically they see. I have no other, heart issues or, health issues. So I got put on rhythm medicine, and it just made my palpitations worse. So I was given a little information about cardiac ablation, and I read up more about it, and I decided pretty quickly that's what I want to get. And so I was in an HMO. I had the HMO electrophysiologist, met with him. I was a good candidate. So I had my first ablation in 2008. And it lasted for 7 months. I did have complications. afterwards. I had pleural and pericardial effusions that eventually after 14 months, they, those symptoms went away. So I was back in touch with the electrophysiologist, and he was not willing to do another ablation. For what reason, I'm not sure. So we tried another different kind of rhythm control med, and that wasn't really effective. So I asked for a second opinion and got referred to a different electrophysiologist, who then did a second ablation in a different center, a nationally known electrophysiologist, very experienced. He told me at the time it might take another touch-up. And so that second ablation lasted 9 months, but no complications. Heart was very quiet and happy. And then I needed a touch-up a year later. So I had a touch-up a year later. That's been 12 and a half years ago. So I was able to return to regular activity pretty quickly after each one of those. I still exercise really regularly. I've had to decondition myself a little bit because I'm one of the few women's cyclists or endurance athletes that have this issue. But I still do my activities. I will say that I just turned 65 a few months ago. So now I have risk factor number 2. And so I was recently prescribed to be back. My old cardiologist did the risk assessment and said, your risk factor number 1 being female, and you're not having detectable AFib episodes anymore, you don't need to be on anticoagulant. So I was not for 7.5 years. But now I have risk factor 2, being 65 and female. So I just got my prescription for that. And so, that's what's going on with that. So
Thanks, Genevieve. That's an incredible 9.5 years. I mean, to live with that and not have a diagnosis, that I can understand how that, took a toll on you physically and mentally, as you described. I'd love to bring Ronda into the conversation. Ronda, you were also diagnosed with several years ago. If you can share with us your journey, we'd love to hear about it. And since your ablation 10 years ago, you've been managing your AFib. So what factors went into your decision about what types of treatment and care you received?
Well, first of all, I think want to talk about the difficulty of getting diagnosed. I'll be 77 in June. And about 12 years ago, I was getting the symptom that was most distressing to me was getting seriously out of breath at irregular times, sometimes after I walked up a couple of steps, sometimes out of the blue. And I would have this sort of gasping for breath, not just out of breath, but gasping for breath. And went to, was referred to my cardiologist. Now, this is also in a rural community, so we don't have a lot of the specialists. I did see a cardiologist in another town who put me through all the assessments that you go through, and including an angiogram. And at the angiogram, afterwards, he announces, I have nothing wrong with my heart. I was clear. My arteries were clear. There was nothing wrong with my heart. I go away discouraged because something was wrong. It's like I had the shortness of breath, I had fatigue almost all the time. I just wasn't feeling good. I went to my primary care physician. He refers me to a local cardiologist. I see him. He looks at me, reviews everything, and said, oh, you, including a one-day monitor. Back in those days, it was the old clunky thing that you wore.
Yeah.
And then he said, you're unconditioned. And that makes me irritated because, again, I knew it was my heart. I knew that. See my PCP, complained, had a little temper tantrum, said I'm never going back to another cardiologist again. He talked me into going back to the cardiologist I saw, who said, well, let's do a 4-day monitor. So I'm called back into the office early. I had like a month appointment. He called me back early, said I was in AFib a certain amount of time. That I read up to, did Google, looked at some legitimate sites, realized that I did want an ablation even before trying the medications. But of course, we had to try medications. They didn't work. I had the ablation. Things seemed to be okay for about a year. I don't think I had anything going on 2 years. But then I had some problems again. And then it was diagnosed that I had left bundle branch blockage and now my heart wasn't synchronized. Then I wound up getting a synchronizing pacemaker with the lead to the left side of the heart. That sort of improved things for a while, but then didn't. And then they adjusted the pacemaker so it would work better. That used up a lot of batteries, so that I was needing every 2 years a replacement. So this is the point where I'm moving to my daughter's, who is close to UC Davis Medical Center, transferred to there. They've done wonders, but I'm still having some AFib now and then. I'm still going on. It's hard to pick out what is AFib, what is part of my heart failure, what causes this other symptom. So right now, medication is working. I'm due for another pacemaker soon. I am deconditioned now because I had knee replacement that didn't go well. I haven't been able to exercise. So some of the things I've done is like, I did lose weight. And there are things that I realize that are triggers. My anxiety is a trigger for AFib, so I have to work with meditation. Certain things, it's like caffeine. I had to cut out my morning coffee. That was hard. There's things I can do to settle down things, but the AFib is still there, but it's not I'm on different medications. So right now I'm living with occasional AFib. I wish I was healthier. It gets a little frustrating, but right now things are pretty well stable. And so I'm happy about that.
Great. Great. Thank you, Rhonda. And I want to bring it back to Dr. Poole and Dr. Volgman, because, I mean, it sounds like our champions have had a really tough time of this diagnostic process. And I wanted to get your views about, is this the plight of many women or many people who are, need a diagnosis of AFib?
Well, I mean, I'm not sure that we know what the denominator there is, right? We don't know how many people are living out there who have atrial fibrillation undiagnosed. I think that one important point is that these are two very different stories. So it's important to understand that there are people like Genevieve who have atrial fibrillation without any other obvious heart problems. but, have atrial fibrillation. And that may be because we do know that there are individuals who are at a high genetic predisposition for having atrial fibrillation. Often, if you do a family history, you find out that other people have had atrial fibrillation, or it may just be something, unique to that person. And Rhonda, I'm really sorry to hear about all the troubles you had with your story also. And I think your story brings up a number of good points. You did mention anxiety, and I think, it's important that we clarify that I think anybody, male or female, when their heart is off to the races, everybody's going to feel anxious. I mean, it is a terrible feeling to have your heart going fast, but that is a different concept than somebody who has a true arrhythmia being ascribed to anxiety because it has not yet been diagnosed, right? So those are two things which I think are separate. It sounds as if, Rhonda, unfortunately, that you have struggled with heart failure, and heart failure can be on the cause of many, many different reasons. And certainly we know that atrial fibrillation that is not well rate controlled can worsen that heart failure, but that still the person has heart failure unrelated to having had atrial fibrillation, but they go hand in hand. It gets kind of complicated. I think you have exactly described that situation that you're dealing with heart failure. I'm really glad to hear that you had the resynchronization device and that people have been continuing to work with you. The other point I would make is that you haven't wiped out all of your atrial fibrillation, and that is more common than not. And that's why I made that point up front, that for the majority of people, we're not expecting to completely cure or eradicate all atrial fibrillation. We want to control it as much as possible through medications, ablation, and kind of just all the things that actually you talked about to minimize how much atrial fibrillation that especially people who have a history of heart failure actually have.
Yeah, thank you, Dr. Poole. Dr. Volgman, thoughts on the journeys that our two champions have been on?
I'm so sorry to hear about that because, this has been an issue with so many women who, I built the Heart Center for Women 20 years ago for this reason, because women are not being listened to. They're often not taken seriously. And this is well documented that when a woman comes to a doctor, they often say, it must be your stress, it must be your anxiety. And you know what? We are trying to empower, and that's what WomenHeart does. We're trying to empower these women to seek help somewhere else. Forget that doctor who tells you that, it's all in your head or you're just anxious. Seek a second, third, or fourth opinion. I would love to see, a way with telehealth that you can go, get a consultation online or through televisit because of the disparities of care that we're seeing in rural versus urban, in women versus men. And I think it would help if we had something like that. And so maybe we could advocate for that, Selena.
Yeah.
No, absolutely great. I mean, I think this anxiety thing is really got to be, it just has to be ended. And Genevieve, your story is really classic. We could, the thing about it is most humans, whether they're men or women, actually know if they have an anxiety disorder, right? I mean,
exactly.
They know that, and they know that feels very different than sudden onset of your heart going up to the races, right? And, to try to, tell somebody that's trying to tell you to go see a psychiatrist that, look, I'm not an anxious person. I'm actually really, healthy person. And I go from feeling fine to suddenly feeling awful. Or in your case, Genevieve, exercising, you're, doing your thing, exercising, and suddenly, that your heart rate is doing something that is not part of just an exercise in, a normal exercise induced heart rate. So it's getting people to really listen to the patient. I think that's where women just, often are not listened to. And it's just too easy to slap that anxiety diagnosis on people.
And it does a real disservice to psychiatry, right? It does a real
Yeah.
disservice to those who legitimately have an anxiety disorder.
Yeah.
It feels to me like a non-diagnosis, which really gets me annoyed as well, and more than annoyed, but really angry. First, thank you, Dr. Volgman, for answering a bunch of the questions that came in. All of you who asked are in good hands. But in the last couple of minutes, because we're really coming to time here, I want each of you to think about, what would your advice be? What would your call to action be for all of those who are listening? We got so much wonderful engagement during this hour because it's an issue. It's clearly an issue that folks have questions about and folks are struggling with at home. So for each of you, I'm going to just sort of go around my screen here to share what would your piece of advice be for those on the call. Let's start with Genevieve.
Well, I found out something interesting very recently. So I have an Apple Watch. It requires, it's not a passive heart rate monitoring. You have to actively push. So that's kind of hard to do when I bike. But I'll do it at home sometimes. I went to an electrophysiologist recently, and he actually asked to, can I see your Apple Heart app results? I never even knew that those things were kept. So I think documentation is really, really important.
Yes.
And the other thing I learned at the car dealership when I brought my vehicle in for repeated problems that just couldn't be solved was be nice, but be persistent. And so I think that applies to a lot of things in life, but I needed to be persistent both in the original diagnosis. I kept thinking, man, maybe it's in my mind, but I need to, keep following this. And then in the process of getting the treatment and the second opinions, so that's my advice: is be nice and be persistent.
Great advice. Let's go to Ronda.
I'm going to say the same thing. I would say go to the large medical centers or the university hospitals, at least for an assessment, because treatment can be done by someone else once the assessment is done, but pursue getting an assessment at a larger facility. That's important.
Thanks, Rhonda. And also, don't take no for an answer, I think is part of what we're saying here. Dr. Volgman, your words of wisdom.
I echo those recommendations. Be persistent. Find a doctor that you trust, because when you have a good relationship with a doctor, they will help you.
Yeah.
And they will not be too proud to say, you know what, I don't know the answer to that, but let me get you somebody who can help you. And that's a good doctor.
Absolutely.
So, establish a good relationship with your doctor who can help you.
The word partner comes to mind, Dr. Volgman. If you can give your doctor as a partner to your health, that's when you've found the right person.
Exactly. And a lot of medicine now is going to shared decision making, because we need to explain all the risks and benefits of the things that we do. And it's not always clear cut what is the right thing for that one person. There's so many options, there's so many treatment, but for you, what is the right thing and what do you feel comfortable with?
Absolutely.
So partnership is a good one.
Thank you. And Dr. Poole.
Yeah, I echo all of that too. I think in terms of the diagnostic part of it, when you know that there's something wrong with you and you're told, oh, everything's normal. Well, maybe the one thing that they looked at was normal, like your coronary angiogram. That's fantastic that that's normal, right? But that doesn't mean that you don't have a primary electrical problem going on that maybe portends some other heart issue that might show up, down the road. So I think being persistent and you have to be your own advocate. I mean, that's true of everything in medicine. You have to advocate for yourself and just, follow that gut that something is wrong. And so, if that requires getting a second opinion, then that's what you do. And then in terms of, treatment, I also want to really emphasize that when you're listening to somebody give you advice about treatment, make sure that you ask questions, no matter how, stupid or dumb that they are, because they never are. They're always the critical questions when you actually open up your mouth and ask them. Like, for me, what is the risk in my particular situation for taking a rhythm controlling medication, getting a catheter ablation, getting a repeat catheter ablation? Are there any other new therapies on the horizon that perhaps, might be something that are good for me? So it is so important to ask those questions and make sure that you are satisfied. And, the other thing is to make sure that it's okay with that physician. And of course, it absolutely should be that when you go home and you talk to friends or family about all of this and you think about other questions, that it is absolutely okay to send them a message through your electronic medical record or, whatever the contact is to get, further questions answered, to make the best decision for you. In the end, it is your body and your health. And so you have to be absolutely 100% confident that whatever the management plan is, that you're feeling very comfortable with that. And again, as Annabelle said, it is shared decision-making with your whole health provider team.
Thank you so much, Dr. Poole. And I'm going to add my 2 cents, which is if you need encouragement, come to WomenHeart. We have champions that will give you that encouragement and tell you about their own journeys. So if that's what you need, we are here. We are here for you. I want to thank all of you. This has been such a robust conversation. Thank you especially to Genevieve and Ronda for sharing your stories.
Yes, thank you.
Thank you to our sponsors, BMS Pfizer Alliance. Thanks to Jody and the incredible folks at Mended Hearts, our partner on this project. We're going to be releasing together a discussion guide on AFib. So please look out for that. And that will to help you think about how to make sense of all of this. And following this discussion, you'll receive a short survey. We'd really appreciate it if you were to take that so that we can improve how we do these conversations in the future. Thank you, Dr. Volgman. Thank you, Dr. Poole, as usual, for your great expertise. And have a great day, everybody.
Bye,
Thank you, everyone. Bye.
Bye.